Hello guys and gals, I am Shania Calisadio, a student nurse from Visayas State University. Today, we are talking about urinary incontinence. Urinary incontinence. This is the involuntary loss of urine from the bladder. Types of urinary incontinence. First is stress incontinence. This is the involuntary loss of urine through an intact urethra as a result of sneezing, coughing, or changing position. This happens to women who have had vaginal deliveries. This is thought to be the result of decreasing ligament and pelvic floor support of the urethra and decreasing or absent estrogen levels within the urethral walls and bladder base. This also happens to men after a radical prostatectomy for prostate cancer. This causes loss of urethral compression that the prostate had supplied before the surgery, and possibly bladder wall irritability. Urge incontinence. This is the involuntary loss of urine associated with a strong urge to void that cannot be suppressed. The patient is aware of the need to void, but is unable to reach a toilet in time. An uninhibited detrusor contraction is the precipitating factor. This can occur in a patient with neurologic dysfunction that impairs inhibition of bladder contraction, or in a patient without overt neurologic dysfunction. Functional incontinence refers to those instances in which lower urinary tract function is intact, but other functions, such as severe cognitive impairment, make it difficult for the patient to identify the need to void, or physical impairments make it difficult or impossible for the patient to reach the toilet in time for voiding. Iatrogenic incontinence refers to the involuntary loss of urine due to extrinsic medical factors, predominantly medications. One such sample is the use of alpha-adrenergic agents to decrease blood pressure. In some people with an intact urinary system, these agents adversely affect the alpha receptors responsible for bladder neck closing pressure. The bladder neck relaxes to the point of incontinence with a minimal increase in intra-abdominal pressure, thus mimicking stress incontinence. As soon as the medication is discontinued, the apparent incontinence resolves. Lastly, mixed urinary incontinence, which encompasses several types of urinary incontinence. This is involuntary leakage associated with urgency and also with exertion, effort, sneezing, or coughing. The diagnostic procedures involved for urinary incontinence are the following. First, bladder stress test. Second, Bonney test for women if necessary. Pad test, X-rays or ultrasounds. Urodynamic testing such as uroflowmetry, pressure flow studies, post-void residual volume, and cystometry. Then, electromyogram or EMG, cystoscopic exam, cystourethrogram. The laboratory procedures are the following: urinalysis and urine culture. Treatment modalities for urinary incontinence. Behavioral strategies such as bladder training or timed urination. Pelvic floor exercises such as Kegels. They strengthen the muscles that control the flow of urine. Kegel exercises are sometimes taught using biofeedback. Changes in your diet and lifestyle. Medical management. Medical devices. For women, women may use a device called a pessary. It can help with bladder control. For men, men may use a catheter to empty their bladder and control leaks. Anticholinergic agents, tricyclic antidepressant medications, pseudoephedrine sulfate, which acts on alpha-adrenergic receptors, hormone therapy. Surgical management for urinary incontinence includes the following: Periurethral bulking. Women with stress incontinence may undergo an anterior vaginal repair, retropubic suspension, or needle suspension to reposition the urethra. Artificial urinary sphincter. Men with overflow and stress incontinence may undergo a transurethral resection. The following are nursing managements. Patient education, strategies for promoting urinary continence. Increase awareness of the amount and timing of all fluid intake. Avoid taking diuretics after 4 p.m. Avoid bladder irritants such as caffeine, alcohol, and aspartame. Take steps to avoid constipation. Drink adequate liquids. Eat a well-balanced diet high in fiber. Exercise regularly and take stool softeners if recommended. Void regularly, 5 to 8 times a day, about every 2 to 3 hours. First thing in the morning, before each meal, before retiring to bed, and once during the night if necessary. Perform all pelvic floor muscle exercises as prescribed every day. Stop smoking. Smokers usually cough frequently, which increases incontinence. For behavioral therapy to be effective, the nurse must provide support and encouragement. It is easy for the patient to become discouraged if therapy does not quickly improve the level of continence. Prognosis for urinary incontinence. People with incontinence often live with the condition for 6 to 9 years before seeking medical therapy. Living with urinary incontinence puts people at risk for rashes, sores, and skin and urinary tract infections. Effective treatments for this common problem are available in many cases. And that's about it for urinary incontinence. I hope you learned something. Once again, I am Shania Kilisadio, a student nurse from Visayas State University. Bye!